Very pleased to have with us Dr. Howard Frumkin. He's the author of many scientific articles, especially in the field of the built environment and health.
Thank you very much, Louis. I appreciate the introduction, and good morning, everybody. Thank you for coming. What I'd like to do is ask you to imagine that you are not a public health professional or an architect or a planner, whatever your profession is, but imagine that you are a zookeeper. And you receive a call one morning that a shipment of butterflies or fish or frogs will be arriving at the zoo. What's your first thought? Your first thought is how to create a healthy habitat for those butterflies or frogs or fish, because you know that if the habitat isn't properly constructed and maintained, they won't thrive. And your measure of success will be their health, their reproduction, their general fitness. It's amazing how rarely we think of the human habitat in the same way, although we know that ecocities, that cities in general, that neighborhoods, that individual buildings such as houses are human habitats. I'm going to ask you to think about what it would take to create healthy human habitats. I made a list of 18 possible candidate criteria, and here they are. I could have put 19, but I ran out of space on the slide. And you can see that I've put some needs that people have. These are not an exhaustive list of human needs, but these are needs that we have reason to believe may be related to the built environment. People need regular physical activity. They need clean air and water. Natural light is better for us than artificial light. Fresh, nutritious, uncontaminated food, which is very much a function of the design of the environment writ large. Not too much noise, the right combination of humidity and heat, some privacy. Too much density is not good for us, but at the same time, we do need contact with people, not only on a moment-to-moment basis, but the general social networks that are called social capital, which can be promoted by the design of the built environment. Contact with nature is very good for us. Legibility, a comprehensible environment, is good. We need to be relatively protected from injuries. We need to be protected from toxic chemicals. We need to be protected from crime. We need beauty and inspiration in our built environment. If disasters should occur, and we know that some kinds of disasters will become more common with climate change, we need to be protected from those. Social equity is a very important determinant of health. And conversely, we have a great deal of emerging evidence that social inequities undermine health. And hope for the future. This is really the story of sustainability, that if people live in situations that they know are unstable and that may deteriorate over time, if they know that their children won't have as secure an environment as they do, that too is dispiriting and undermines health and well-being. Well, this is a long list of criteria. I suspect that we would not have much disagreement in the room about any of these. You might have a few criteria that I forgot. You might suggest taking some off. But in general, this is a fairly straightforward list of features of healthy human habitats. Now, I go through this in detail because it's remarkable, and we're reminded at a meeting like this that very often as we talk about human habitats, we forget to think about these criteria. In fact, in much of the meeting, although there is absolutely excellent work being reported here, health is not mentioned very routinely. It's not a standard reflexive part of our discussion about Ecocities. Here's an example, and I offer this example with great respect for the work of the Equilibrium Communities Initiative by Natural Resources Canada and the CMHC. When projects were given out to encourage sustainable communities by the Equilibrium Communities Initiative, the criteria for choosing projects were those that you see listed here. And you'll notice that although each of these has something to do with human health and well-being, explicitly there's no mention of human health or well-being. And when you look at the performance indicators that are used in these projects, again, you'll see a few that are relevant to health directly or indirectly. For example, number 10, pedestrian safety. But in general, human health is very difficult to find here. Now again, I say the Equilibrium Communities Initiative is excellent work. We all have to support this kind of work because it advances Ecocities and it advances human well-being. But the deep thinking within the project generally tends not to look very much at health. So what I'd like to do today in our time is to look a little more at health. Let's ask the question to begin with, how are we doing at creating human habitats? This is a question we could ask and consider on many spatial scales, from the entire globe to metropolitan areas. But I'd like to look at this question as an example just at the level of the street. Are we creating human habitats that enable people to move safely and in physically active ways through the environment? Well, I've performed a careful study and I've discovered the existence of a national Never Walk campaign across the United States. And in several years of observations, what I've discovered is that there are 14 strategies that are used by the people who manage this campaign. The first strategy is not to build sidewalks, and so this is the standard configuration of the road that the campaigners like. Now, unfortunately, if you look to the left, you'll see that people do insist on walking. Some people don't have a car. Some people aren't physically able to drive a car. And so there they are. These are people who walk anyway, and that means that the campaign needs additional strategies to prevent people from walking. Building repellent sidewalks is a useful strategy. Here's a sidewalk that offers no buffer between where people walk and the street. There's nothing interesting to look at as you walk along the sidewalk. There's nothing to shade you from the sun, so it's no wonder that nobody wants to walk on a sidewalk like this. The third strategy is deferred maintenance, allowing sidewalks to disintegrate like this. Too often when our municipalities don't have funds to maintain infrastructure, sidewalks are the first part of the infrastructure to go. The fourth strategy is to build treacherous sidewalks. This is a sidewalk that slopes down into traffic. So if you're a parent and you're pushing your baby in a stroller on a sidewalk like this and you temporarily lose control of the stroller, it will go into the street, your baby will be removed from the gene pool, and that will reduce the possibility of more people walking in the future. Obstructing sidewalks sends a very important message to people who would like to walk about how much we value walking. This is a stretch of sidewalk about 100 meters from the Centers for Disease Control headquarters in Atlanta. We had a storm in Atlanta. The tree blew down. The highway department came very quickly, and with their chainsaws, they sawed the tree off. Now, they could have sawed the tree off on the inside of the sidewalk, but that would have allowed pedestrians to pass. And so, as you can see, they were part of the National Never Walk campaign and sawed off the tree on the outboard side. This is a very frightening situation for most of us. Strategy number 6 is to use creative design, including using medical themes to include the health professions. So this is called sidewalkus interruptus. This is called dislocation. Strategy number 7 is that crosswalks, which are of course available to help pedestrians go from place to place, should go no place. And if the crosswalks go no place, nobody will ever use them. Strategy number 8 is to place mortal dangers where sidewalks and pedestrians usually go. This says, move to the side of the road when a vehicle approaches. Strategy number 9, at a time of economic desperation, is to combine multiple strategies for more efficiency. So here you have a deteriorating sidewalk and obstruction, a very effective message. Here you have obstruction plus sidewalkus interruptus. Strategy 10 is executed on a larger spatial scale. Never place an interesting or useful destination within walking distance of where anybody lives. In the sprawling neighborhoods that characterize many of our cities across the continent and across the world, purely residential areas like this one are built with no stores, with no schools, with no recreational facilities. So any trip, even for a loaf of bread or a quart of milk, has to be a trip made by automobile. Strategy 11 is pictured here, and before I tell you what it is, let's see if you can guess. Do you think this is A, a factory, B, a spaceship that just landed from another planet, or C, a school? Yeah, this is a school. This is a typical configuration of schools in many sprawling communities. In fact, this phenomenon was described as edge-ucation by Governing Magazine, a magazine for elected officials. The to place schools in the middle of nowhere. So we see schools that are placed in locations like this, engineering into the situation the reality that no child will ever walk or bike to this school because the distance from home is much too great. This is my favorite example. This is the Hubbard Lake Elementary School in Michigan, whose motto is outstanding in its field. This precludes routine physical activity for children in getting to school. Strategy number 12 is to be explicit and just say it. This is the entrance to a gated community, which is one of the fastest growing residential configurations in the United States. And if you look carefully at this gated community, it says no pedestrian. So you're not allowed to arrive on foot. You have to have a car. And finally, next to last is to turn parking places into architectural icons. Have you noticed how many houses look like this? They present to the street and to the public not architectural grace and beauty, but a large opening for a car. Now, I'm not an architect, but to me this is no different than presenting a large orifice to the public in a not very graceful way, emphasizing the importance of cars. And finally, make everything car accessible. Create a drive-through culture. Drive-through pharmacies, drive-through dry cleaners, drive-through liquor establishments. Notice, by the way, that drive-through is always spelled T-H-R-U. Now, the word is actually O-U-G-H, but the campaigners know that busy drivers have better things to do than to read long, difficult words. Drive-through bakeries, drive-through grocery stores, drive-through automobile service, drive-through food, which you can then wash down with drive-through coffee. Drive-through banking, and this is a very interesting example. If you look carefully at the console of the ATM, what you see is that there are braille buttons, so even blind drivers are able to use this. We have drive-through opportunities to mail mail, drive-through opportunities to pay utility bills, drive-through opportunities to buy flowers for your loved one. If that leads to a marriage, you don't have to get out of the car to get married. Only in Las Vegas, as far as I know. If the marriage doesn't last and you have a divorce, you can pay your child support payments by driving through at this window in the courthouse. And speaking of life cycle events, increasingly popular drive-through funeral homes, break for the wake. Drive-through trees, being that we are a nature-loving people, this is an old custom and it continues to the present. How about drive-through medical care? Is this the next frontier? This is a drive-through flu immunization. And this actually existed during the last round of flu shots that we gave. It's very efficient because the driver can stick her arm out the window and get her shot. But if we can do that, why not drive through blood pressure checks? Why not drive through dental services? In fact, with only minor modification of automobiles, we can consider drive-through sigmoidoscopy, which would be a breakthrough in preventive health care. Now, this is one that I can't explain, and if anybody can explain it to me, I'd like to hear the explanation. And this is one that I don't want to explain. But all of this conspires to create a pedestrian and bicyclist hostile society, as pointed out by USA Today. And that is, of course, not the only way in which we've created a habitat that may not be the ideal one in which humans can thrive. Let's consider several ways in which the design of the built environment impacts health. And as I go through these, I'm going to talk about theoretical constructs, but mostly I want to present to you examples of data. And I want to make the point again and again that rigorous health research can be done and is being done to help us understand the links between health and the built environment and to give us guidelines so that we can use evidence-based design to create human habitats that we know are healthy for people. So the physical activity story is the first one I'll discuss. I'll discuss 3 more after this. And I've referred to this a lot in showing you the pictures that I just showed you. The theory here is that a non-walkable environment contributes to sedentary lifestyles. Being sedentary contributes to overweight, and being overweight contributes to adverse outcomes. And in addition to that, independent of body weight, being sedentary contributes to adverse outcomes. In fact, here you'll see that the impact of inactivity and of overweight independently of each other is extremely diverse and affects most of the major causes of morbidity and mortality that we face. Overall mortality, cardiovascular disease, cancers, depression, and on and on. This list, again, could be longer if the slide were bigger. So keeping people physically active and keeping people at normal body weights are extremely important health goals. We haven't been meeting those goals. You may have seen these obesity maps from the Centers for Disease Control in the US. The darker the color, the higher the prevalence of obesity. This is 1985. This is 88, 91, 94, 97, the year 2000, 2003, and 2006. So we have a steadily progressive epidemic of obesity and overweight in the country. And this is, of course, not unique to the United States. It's common in many of the developed countries in the world and becoming common in developing nations as well. The maps that I showed you showed adult data, but childhood trends are very similar, as you see here. This is a very, very important public health problem. Do we have research to suggest that physical activity and or body weight can be affected by the built environment? Let me show you a couple of examples. This is a published paper from 2003. It was a cross-sectional study looking at participants in the behavioral risk factor surveillance system. This is a routine national survey that we do in the States regarding health factors. 200,000 people were studied. The hypothesis is shown in very simplified form there. The hypothesis is that urban sprawl could lead to poor health outcomes. The independent variable, urban sprawl, was measured by something called the sprawl index that you may have seen. It's an index that combines land use mix, connectivity, residential density, and activity centers, and it was assessed at the level of counties or metropolitan areas. That's the independent variable. The dependent variables were several, and you see them listed here. Physical activity, obviously this is a behavior, both leisure time physical activity and overall minutes walked, and body weight and certain health outcomes. So it is certainly possible in an observational study to look at whether the built environment influences these important outcomes. What the investigators found was mixed. Physical activity was not associated with sprawl in connection with leisure time activity, but it was associated with minutes walked. The less sprawling a residential setting, the more people walked. The built environment determines physical activity. The built environment had an impact on body weight and on obesity, although only at some spatial scales and not at others, raising some interesting questions. And sprawl did have an impact on blood pressure, although not on diabetes or coronary heart disease. Another example of this kind of health research is the study called SmartTrack that was published in 2004. It was a cross-sectional study of almost 11,000 adults in Atlanta. Very similar overall theoretical approach. The hypothesis was that the built environment would impact people's health. The independent variables were connectivity, land use mix, and density, and those were examined independent of each other, not combined into a single index. The dependent variables were travel behavior and weight, and the investigators very properly controlled for other potential confounding variables. A feature of the study that was very appealing was a very sophisticated approach to the independent variables. You see on the left a disconnected neighborhood, and on the right a connected neighborhood having to do with intersection density and block length. You see that the network buffer was used in addition to the crow's fly distance buffer. So a very thoughtful and quantitative approach to the built environment. What they found was that the probability of obesity on the y-axis decreased with increasing land use mix, and that the probability of obesity increased with minutes spent in a car every day, a direct function of the transportation and land use decisions, and the probability of obesity decreased with the walking distance per day. So exactly the kinds of conclusions you would expect. There's much more research. This has been a booming area of research in recent years. Time spent bicycling is associated with green and recreational space. This is a direct message to urban planners who are deciding how and where to build bicycle trails. Living near footpaths is associated with an increased likelihood of recreational walking. Again, this is a message to urban planners and designers. Walking and biking rates are higher in denser neighborhoods, and when children go to smaller schools, they're more likely to walk or bike to school. Transit users, interestingly, walk a median of 19 minutes per day getting to and from transit, and about a third of them reach 30 minutes a day of physical activity, meaning that mass transit is an effective route to promoting physical activity and therefore is a public health intervention. So each of these is an individual study result. I could go on and on. The point here is that we have an increasing body of increasingly rigorous and solid research showing us the associations between the built environment and health, and physical activity in particular, and showing us that design features are able to be characterized. What about at the smaller scale of buildings? One of the interesting features that I've seen, I'm sure you've seen as you've traveled and stayed in hotels, is the monumental architectural importance of the labor-saving device. In this case, the elevator. The Hyatt Regency hotels are famous for this, but lots of other hotels make sacred the elevator. Meanwhile, if you look for a staircase, it's liable to be a clandestine affair, hidden behind cinder block walls and difficult to get into if you have to. Why not architecturally build the kinds of stairs that seduce people into wanting to use them? The Louvre, this is a building called the Swan House in Atlanta. This is the Biomedical Research Institute in Sydney. This is a great bookstore in Porto, in Portugal. This is a quotation from Tom Penny, who was the president of the AIA, the Architects Association in the States, in designing their space for their firm, which includes this staircase. These stairs have become a gathering meet and greet space for us, as well as a way to get from the first floor to the third floor. Since we moved into our new office with its convenient, attractive stair, almost no one uses the elevator. So mixing the human need for social interaction with the human need for physical activity and achieving both through good design of staircases. Overall, we do know enough to begin to enunciate design principles to promote physical activity. At the community scale, many of the features of smart growth or new urbanism, mixed use, density, good pedestrian and bicycle infrastructure, connectivity, safety, green space, and the presence of other people out walking are all predictors of physical activity and therefore of lower body weight and of improved health outcomes. At the building scale, seductive staircases do function to get people walking. Second example of how the built environment may impact health is air quality. Now, you know that air pollution is a mixture of a range of different components, and the air pollution in one city is different than the air pollution in another city. To begin this discussion, let's remember that all of the pollutants shown on the right are the result of motor vehicles. And so, all things being equal, the more automobile traffic, the higher the levels of those pollutants. In fact, as you can see here, large proportions of some of the major pollutants, oxides of nitrogen, hydrocarbons, and carbon monoxide, do result from motor vehicles. And ozone, which is a secondary pollutant, doesn't come directly out of tailpipes, but it forms in the atmosphere as the result of chemical reactions of NOx and hydrocarbons. In many cities where ozone is the most important air pollutant, motor vehicles are the most important determinant of ozone levels. Here's an example from Atlanta. This is a tracing of ozone levels during the course of a typical day, and you can see that at about early afternoon, the ozone levels rise to the point where they just pass the threshold for danger. One of the reasons that happens is shown here. The yellow bar represents the morning rush hour, when the local airshed is loaded with hydrocarbons and oxides of nitrogen. Those react under the influence of heat and sunlight as the day goes on. The airshed is further charged with those ozone precursors in the afternoon rush hour, and that helps maintain the levels of ozone at unhealthy levels. Ozone matters. It's a respiratory toxin. It has cardiovascular effects. It probably has immune system effects. And like many environmental exposures, it doesn't affect all of us equally. Certain susceptible subgroups, the ones that you see listed at the bottom of the slide, are especially liable to suffer from the effects of ozone. Now, change is possible. If we change travel patterns, we can reduce ozone levels and we can reduce the consequent health effects. We did a study in Atlanta in 1996. It was a difficult study to do because it involved bringing the Olympic Games to Atlanta, but that's what we needed to do to decrease motor vehicle use in Atlanta for a couple of weeks as a trial. So the Olympic Games came, all people in Atlanta were told, please don't drive, the streets will be terribly congested. And what happened was that peak traffic levels declined, not drastically, by 23%, so a substantial decrease And that was enough, as you can see at the red arrow, to lower peak ozone levels by 28%. During that 2 to 3 week period of time, asthma emergencies in children decreased by as much as 44%, depending on what the metric was that's used. Visits to emergency rooms, hospitalizations, visits to physician offices, and so on. At the end of the Olympic Games, the driving was restored to its normal level. Ozone came right back up to where it had been at baseline, and the rate of asthma emergencies returned to its baseline. A clear example of how transportation decisions lead to air quality changes which have direct and immediate health impacts. But the air quality issue isn't just an issue of transportation, it's also an issue of buildings, of structures. Indeed, these are the places where we spend most of our time. The impact of buildings operates on air quality in several ways. First, if we build buildings according to healthy and green principles, we improve the air quality in the buildings. This is not necessarily straightforward. In fact, beginning in the 1970s with the energy crisis, when we began building tighter buildings, we actually decreased air quality because there was typically less exchange of outside air, and we do need the exchange of outside air. We now know much more about building buildings in ways that are both environmentally friendly and healthy. It's very important to keep both sets of design considerations in mind as we build buildings. And the way the buildings are operated, the way they're cleaned, the way pest control is accomplished, and so on, also extremely important in maintaining healthy internal environments for people. The way buildings are powered is very important as an air quality and health issue as well. Buildings are the place where a large proportion of energy is used, and much of that energy across much of the world comes from coal. I'm fortunate to live in an area that relies heavily on hydropower, but across the US, across much of the world, coal is the main source of electricity used for buildings. We all know that the coal life cycle, from the point where miners remove coal from the ground to the transportation of coal across long distances leading to pollution and to injuries, to the combustion of coal leading to air pollution, and finally to the disposal of coal waste leading from time to time, including last year, to enormous disasters. All of this is an energy pathway that has serious negative health implications. In particular, the piece that has to do with air quality, the topic of this portion of the conversation, has been well studied. We know from the classic 6 cities studies and from numerous other studies that air pollutants related to coal combustion are an important source of increased overall mortality, of pulmonary disease, and of cardiac disease. Here you see mortality data showing a close association between the air pollution levels, shown with little smokestacks, and the mortality levels shown with bars. Last way to think about air quality. Clean air is something that trees help us achieve. Trees sequester a number of air pollutants, and especially in the urban setting where we have concentrated sources of air pollutants, planting trees is a strategy to achieve cleaner air and better health. Now, again, this is not an unmitigated blessing, and we need to consider the complexity here. There are two sides to many stories, and this is an example. Trees also emit hydrocarbons, and in some areas, ozone production is encouraged by the release of hydrocarbons from trees, especially in some heavily forested areas. So the choice of species that are planted in cities and the other emissions that may lead to ozone all need to be considered in thinking about the design elements that include trees. In general, to wrap up the discussion of clean air as a health asset, transportation alternatives, density, mixed land use, all to reduce travel demand, green, energy-efficient buildings that are not only designed and built well but operated well, and trees, parks, and green spaces, all are strategies in the built environment to achieve cleaner air and therefore better health. Third topic, parks and green spaces. Parks are a very important amenity in the built environment. They range from the large iconic parks such as Central Park in New York. Does everybody know where this is? If you haven't been there this week, I encourage you to go up to Montréal. It's an absolutely beautiful urban park, also designed by Olmsted, the guy to whom we owe so much for Central Park in New York and so many other great places, all the way down to small neighborhood parks like this one, not too far from where I live in Seattle, even to the point of industrial archaeology. This is the Gasworks Park in Seattle. This is a former hazardous waste site. It was a coal gasification plant. And the city made the wonderful decision to turn this into a park, so it's a very popular recreational setting now with lots of contact with the outdoors and with nature. Now, parks are good for public health because they provide venues for physical activity, as signified in these pictures. And that may be the most obvious benefit of parks, but it's certainly not the only benefit of parks. To discuss some of the other benefits of parks, I want to take you back to an evolutionary perspective. Evolution, of course, is the study of how we evolved from our early roots to the pinnacle of evolution where we are now. There is an evolutionary concept called biophilia, described by the great Harvard biologist E.O. Wilson, defined as the innately emotional affiliation of human beings to other living organisms. The idea is that over a couple of million years of evolutionary time, we were embedded in nature. For the last 10,000 years or so, a relative blink of the eye, we've been relatively insulated from nature by living in towns and cities, and especially in recent generations in more controlled built environments. But Wilson proposes that there must be some sort of hardwired affiliation with nature because that was the setting in which we evolved, and it would have offered survival advantages to be attuned to nature. There is evidence to support this view, and the evidence pertains to built environment design. Let me show you a few examples. This is a classic study published in 1984 looking at gallbladder removal surgery over a 10-year period in a hospital in Pennsylvania. So all the patients who came in for their gallbladders to be removed were followed. The reason for doing this study was that in this hospital, coincidentally, some of the rooms post-operatively looked out at trees, shown by the green arrow. Other rooms looked out at a brick wall. And the investigators simply compared the experience of the patients who were put into a tree view room to the experience of patients put into a brick wall view room. He limited the period of observation to the seasons of the year when the trees had leaves on them. And what he found was that if you had a view of trees out your hospital room, you had a shorter hospitalization, a faster recovery, less need for pain medications, and fewer negative nursing notes in your hospital record. Something about viewing nature, very simple intervention, seemed to improve surgical recovery. By the way, you'll notice that in 1984, patients got to stay in the hospital for a week after having their gallbladder out. I don't know about Canada, but in the US, it's essentially done on a drive-through basis now. There's real progress in healthcare. This is a study published in 1978 in a large Depression-era prison in southern Michigan. This is the floor plan of the prison. And you can see that there were some cells that gave a view to the inside courtyard, which was a drab, barren, a treeless view. Other cells, shown in green, gave views to the outside, where there was a view of rolling hills and scattered copses of trees, exactly the habitat that E.O. Wilson hypothesizes was our origin in Africa as a species. Sick call attendance from the inside cells was 24% higher than from the outside cells, with no difference other than the location of the cells, suggesting that the view of nature had something of a soothing or a restorative impact on the prisoners. A recently published study in Copenhagen showed that people who lived near parks, who had access to green space, had lower levels of self-reported stress, lower risk of obesity, and even after the investigators controlled for visiting the parks and being physically active, that relationship held, suggesting that the benefits of green space extend beyond physical activity to something else. A recently published study from Indianapolis followed 3,800 inner-city children over a 2-year period, classifying them according to how green their neighborhood was. And the investigators found that the greener the neighborhood, the slower the rate of weight gain and the lower the rate of obesity at the end of 2 years in the children they followed. A study in Tokyo looking at over 3,000 elders and following them up in their elder years collected data on socioeconomic status, home environment, so on and so forth, and followed their mortality by 1997. What they found is impossible to see from this slide, but let me tell you what that says. If there were green assets near their homes, if people had trees or parks Or independently, if they had places to walk, they had a substantially lower mortality rate than if they didn't have the nearby nature in their neighborhoods. And finally, I'm going to tell you about a series of studies carried out at the Robert Taylor Homes in Chicago. This was no longer standing. This was a public housing project in Chicago. 28 identical buildings that looked like this, bounded on one side by railroad tracks, on the other side by highways. And the reason that it became a venue for studying the health benefits of nature contact was this. Some of the buildings had trees outside them, as shown here. Others had barren courtyards outside them. Interestingly, they all had trees planted when the project was constructed, but some of the residents came to feel that the trees were places for predators to lurk and encourage crime, and so the trees were cut down by the people who lived there. In other places, the trees were allowed to remain. When your name came up to the top of the list in the Chicago Housing Authority headquarters, you were assigned to the next department that was available. So it was essentially a random allocation to buildings with trees and buildings without trees. Investigators at the University of Illinois, Sullivan and Quo, carried out a series of interview studies of the people in those buildings and found that if you lived in a building with nearby trees, you had substantially higher probability of knowing and greeting your neighbors, of acknowledging and helping your neighbors. You had less psychological aggression, less violent behavior, and not shown here, but also found the children had better academic performance in school, all associated with the presence of trees near the residential environment. We know that in terms of child development, play is extremely important, as pointed out by this American Pediatrics Association statement. We also are beginning to realize that play in natural settings seems to confer benefits above and beyond the routine experience of play. There's also some early evidence that physical activity in natural settings seems to confer some benefits above and beyond the same level of physical activity with the same caloric output in more built or constructed settings. That has helped lead to a national movement in the US and in many other parts of the world to encourage kids to get outdoors, the so-called Leave No Child Inside movement. But that kind of recreational activity and planned activity isn't the only way to get people outdoors. Community gardens offer another important route, and this has the co-benefit of providing people with skills, with physical activity, and with sources of safe, healthy, wholesome food. So one of the examples of co-benefits, a theme to which I'll return at the end. Design principles to ensure nature contact and all of the health benefits that it confers, adequate trees, parks, and green space, and attention to underserved groups because, as is true across the entire spectrum of public health, not all of us are equally susceptible to deprivation, some more than others, and it's to those groups that we need to focus our attention. The fourth and final of the health dimensions that I'll discuss is injury risks. I'm going to return to the street side or the roadside panorama that I began showing pictures of early in the talk. This kind of roadway is designed to move traffic, and that's the main purpose of it. It's not built for pedestrians, but it does enable us to play a fun game called Find the Victim. So if you look carefully at the picture, you'll see a pedestrian down there trying to cross the road at very high risk of getting hit. In fact, this particular stretch of roadway in Atlanta has the highest pedestrian mortality rate of any stretch of roadway in the metropolitan area. Car crashes remain the leading cause of death of young people in the United States, with a stubbornly persistent toll of about 40,000 deaths per year in recent years. It has come down about 15 years ago to that point, and it remains stable at about that point. Is the built environment involved? Well, it is. Here's a single variable display. This is simply city by city, and it shows the automobile fatality rates in each city. You'll notice that the denser, pre-automobile, more transit-oriented and pedestrian-oriented cities are clustered at the top of the list, and the more sprawling cities that are more automobile-dependent cluster at the bottom of the list. There's about a tenfold difference in automobile fatality rates from the top to the bottom of the list. That tenfold difference represents preventable deaths. Those are people who don't have to die. With better design of the built environment, arguably some or most of those deaths could be prevented. We do have increasing evidence that less driving is associated with fewer fatalities. That means transportation planners are public health professionals. The graphic you see on the left shows the association between urban sprawl and automobile fatality rates, showing that with decreasing sprawl, we have decreasing fatality rates. The graphic on the right shows something a little different, a different approach to the same notion of less driving means fewer fatalities. The upper curve there, let me see if I can show you this with the, yeah. So the upper curve shows the amount of, what's that say, gasoline sales with increasing gasoline prices in recent years. And that's here. The lower curve shows automobile fatalities dropping very precipitously. So higher gas prices, less driving, fewer fatalities. Another route to the same outcome, that less driving, in this case moved by gasoline prices rather than by built environment design, is associated with public health gains. That has been studied a lot. This is a very interesting phenomenon given that we are probably approaching peak petroleum and we may be looking at higher gasoline prices indefinitely. As the prices rise, the amount of driving people do decreases, and as driving decreases, this is simply primary prevention, driving-related fatalities decrease. Now, it's not only the passengers and drivers who are at risk in an automobile-dependent society, but it's also pedestrians. Pedestrian fatalities are unfortunately common. They have diminished in frequency in recent years in the United States, and that's for the good. But it's a mixed blessing. The main reason that pedestrian fatalities are on the decline is because people have been walking less and less in much of the country. Is it the case that there is an inherent trade-off between walking and risking your life? Well, it seems not. And one of the best sources of data we have on this is transnational comparisons. Here you have a comparison of Dutch, German, and US data. You can see that the Dutch and German experience features a far higher share of urban trips that are taken on foot or on bicycle. And interestingly, this is true across the age span. Even if you stratify this by age and you look at the over 75-year-old age group, substantial proportions of trips taken by foot or by bicycle in Holland and Germany. Far lower proportions in the US, and by the way, the Canadian data are almost identical to the US data. The pedestrian fatality rates, though, are much higher in the US than they are in Holland and Germany, and the same is true of the bicycle fatality rates. And that's true if you measure those fatality rates by distance traveled, by trips traveled, by population. So the key to the success in Europe and the key to the poor public health record in the US has much to do with built environment design. If you build safe routes for pedestrians and bicyclists, segregating them from traffic, then their safety is greatly increased. We can push for more physically active transportation and still enjoy the benefits of safety for those who walk and bike through good design. So the design principles include transportation alternatives, getting people out of cars, reducing driving by reducing travel demand through the design of cities and communities, and safe infrastructure for pedestrians and bicyclists. Well, this takes us back to the 18 human needs that I posited early in the talk. I've discussed only 4 of them. There isn't time to go through them all, but the same themes emerge in each of these, the 4 that are in yellow that I discussed. There are evidence-based design principles that help us design habitats that are healthy for people, in which people can thrive. And those principles can be applied across the lifespan. They can be applied especially to groups that are at higher levels of risk, and therefore this is a public health mandate. Now, I've mentioned briefly the concept of co-benefits, and I'd like to begin to close by talking about co-benefits for just a moment. The notion here is that when we design human habitats to be healthy, we can appreciate a large number of cross-cutting goals in many situations. This is a label from a bottle of Bonor's electromagnetic bathing fluid. This was the medicine that my mother raised me on in the 1850s when I was a young kid. And you'll notice if you look at the label carefully that it cured neuralgia, cholera, rheumatism, paralysis, hip diseases, measles, female complaints, and so on and so forth. And it was very effective. I never suffered from any of those things except female complaints during junior high school, but most of us boys did. Well, we actually don't have medications that cure this many things, but we do have built environment design strategies that are this far-reaching and beneficial. Think, for example, of the simple built environment intervention of planting trees in urban areas. Trees help to cool temperatures in urban areas through evapotranspiration and by providing shade. At a time when climate change is making heat waves more and more likely, and when heat waves affect people in cities adversely, especially the elderly, this is an important public health strategy. Trees also reduce energy demand, and that means less coal needs to be burned in power plants during the warm weather to cool buildings, and that means improved air quality. Trees sequester carbon, one of the things we need to do to address climate change. And those and many, many more benefits flowing from a simple intervention, which is planting trees, maintaining green space in urban areas. Think of co-benefits in the transportation sector. This is a mother in the United States walking her children to school. The year is 1957, the last reported time this happened. And what you can see from this is that she is reducing the carbon dioxide emissions that she would otherwise be contributing by driving her children to school. She is also getting physical activity for herself and her children, training them for the rest of their lives that physically active transportation is a viable choice. They're reducing the risk of injuries by not being in their car on the roads. They're building social capital by meeting and greeting neighbors on the sidewalk instead of by cussing at their rivals through the windshield of their car. They are reducing the risk of mom's osteoporosis in case she has any tendency, physical activity being a very effective prevention for osteoporosis. They are reducing their contributions to air pollution. They are reducing mom's tendency toward depression, physical activity being an effective antidepressant. I could go on and on. I'll quit at this point, but just to mention in passing that in addition to all of those health co-benefits, the fewer dollars we have to spend building more road miles, the more dollars we have left for social goods, such as education, health, law enforcement, and so on. So a wide range of co-benefits. And this can be found in many, many domains of built environment design. There are health benefits that cut across many parts of health, and there are other benefits as well. So let me close by offering a few conclusions that summarize much of what I've said. First, consider health, seek solid evidence. I want to place the role of design in perspective by pointing out that it's necessary but not sufficient. Embrace dilemmas, about which more in just a minute. Think long-term, collaborate, and let's train those who come after us. I mentioned at the beginning that too often we forget to think of health when we consider built environment design, when we consider eco-cities, and so on. This is a slide showing a number of the federal agencies in the U.S. government, but it's really just a shorthand graphic way of showing that transportation is an upstream determinant of health, housing is a determinant of health, energy policy is a determinant of health, and so on. So as each of those domains is considered, and this cuts across the entire concept of eco-cities, all of it has an impact on human health and well-being, and we need to work very hard to be sure that health is a consideration in design. As we do that, we need to seek solid evidence. More and more, we are able to invoke evidence-based design because we have the kinds of scientific data that I showed you earlier that guide us in how we make design decisions. Do we know enough? We certainly do not. I can't tell you as I stand here how many trees are advisable on an urban block to offer the benefits of nature contact to the people who walk there. I can't tell you as I stand here how wide sidewalks ought to be to impel people to walk on them more. We need to learn much more, but we know more than enough to act in many of these domains. So the research in the biomedical sphere needs to move from traditional biomedical research to research just as rigorous on the health impacts of the built environment. One of the ways in which to marshal evidence and to demonstrate the shortcomings of evidence to guide further research is through health impact assessment, a semi-quantitative way of considering policy choices in the built environment and of using health data to help guide the very best decisions. This is a very, very advisable approach for planners, developers, and builders to use. Design is necessary but not sufficient. You may have seen this picture. This is the entrance to a fitness club, and there were people riding the escalator up to get their exercise inside the fitness club. It's clear that if you give good infrastructure to people, they don't necessarily do all of the things that we might wish they did to maintain their health. And this is not just true in this picture. This is the staircase that you all came up today. The red circles show people riding the escalators, and the yellow circles show people walking up the stairs. This was taken yesterday afternoon. How many people walked up the stairs today to reach the 5th floor? Okay, so infrastructure is necessary but not sufficient, and we need to accompany the design of the built environment by education programs, by public persuasion, in some cases by regulation, so that we can maximize the health benefits of built environment interventions. We need to embrace dilemmas. Even though I've tooted about the benefits of built environment interventions in yielding multiple positive outcomes, the co-benefits idea, that's not always the case. So for example, the wonderful shared bike system that Montreal exemplifies and that over 150 cities worldwide also have, including good bicycle infrastructure and regulations that are supportive and so on, is counterbalanced by the fact that it's very difficult to get people to use bicycle helmets in the bike share programs. And so this is a dilemma. This is not a debate between those who oppose bicycle helmets and those who like them. This is a debate between the good and the good. Bicycle helmets are good. Encouraging bicycle use is good. And we need to identify dilemmas like this and figure out ways to optimize both goods. Here's another dilemma. Hospital wards, as you see on the left, are very energy efficient. You can put lots of people into relatively small space. That requires less energy to heat and cool the space. On the other hand, single hospital rooms are better because infection rates are lower and people have more privacy. Big windows in hospitals are good because natural daylighting helps patients heal. Small windows are good because you need less energy to keep the hospitals cool in the warm weather and warm in the cool weather. So there are design dilemmas throughout this entire arena. We need to optimize lots of competing good goals, and it helps very much to think about these and to educate young people to deal with them as they do their work. We need to think long-term, and I'm really speaking to the health professionals as much as to anybody here. Most of us who trained as clinical healthcare providers learned to think about the individual patient and care for that individual patient. In my case, and in the case of many of my colleagues, the switch to public health brought with it a switch of perspective to caring for the entire community. But there's another switch that we need to be thinking about as well, and that is caring for future generations. These are people who will never show up either in our clinics or in the voter boxes. These are people we'll never know. But many of the decisions we make today directly will affect the health of those who come 5, 10, 15 generations after us. So this is a more expansive and long-term view of public health than many of us has ever had. We need to collaborate. Here is a proposition, health professionals on one side working together with design professionals on the other side. The exact kind of discourse that we're having in this room now and that this meeting exemplifies is extremely important if we're to design built environments that are good for people. And to do even better than we can do, we need to develop training programs that will combine health professional or health thinking with design thinking so that architects, planners, landscape architects, and others understand the health implications of what they do, and so that health professionals understand the built environment needs of those whom they serve. Well, I've described the idea, I've advocated the idea that we ought to be building healthy habitats for humans as an intrinsic part of the Ecocity concept. I've worked 4 examples of how we might think about that: the physical activity, the air quality, nature contact, and injury prevention. And I've offered a series of conclusions that involve thinking broadly, thinking long-term, thinking in terms of co-benefits, basing the design work that we do on solid health evidence so that we can do the very best for those we serve now and in future generations. Thank you very much for attending this morning, and thank you for the interest that you all have in creating healthy, sustainable, wholesome environments for people.